Hello everyone. Today I'm going to talk about a case of unilateral choanal atresia and my approach of endoscopic crossover flap technique. So this is a case of this is a CT scan of the child, a 9-year-old girl with right side mixed type of choanal atresia, both membranous and bony. She was diagnosed at 28 days of age, and then follow-up scan was done. She had presented with right-sided nasal blockade and purulent discharge from the nose right side. These were her presenting complaints. So I waited till the age of 9 years, and then I did a diagnostic nasal endoscopy just before the surgery, and this is what it shows. There is an atretic plate in the right side choana with a pinhole opening through which air bubbles can be seen. This is on the right side. You can see the air bubbles here, and below you can see the atretic plate in the area of the choana. So this was the endoscopy done in the OPD. And then this is the surgery which I did. So I decided to do a crossover flap technique. So as you can see, I'm putting a 2.7 mm endoscope in the right nasal cavity. You can see the pinhole opening with the bubbles of air coming out through it, and below you can see the atretic plate on the right side. This is on the left side, the patent choana. I kept a gauze piece there. So in the crossover flap technique, it's a septal mucoperiosteum based flaps which I am raising on both the sides. This is on the ipsilateral side. I'm doing the surgery under general anesthesia. So I'm infiltrating the mucosa with 2% xylocaine with adrenaline along the floor and on the septum on the right side, that is the ipsilateral side, and then again on the contralateral side in the lower 1/3 of the septum and posterior 1/3 close to the choana. So infiltrating the floor as well as the septal mucoperiosteal mucosa on both the sides using a 26 gauge needle. So I'm using a lot of adrenaline cottonoids for decongestion and outfracturing the inferior turbinate. Next I use a Colorado needle to raise a inferior based flap based on the septal mucosa right from the floor and then going upwards along the posterior 1/3 of the septum. So I'm marking the incision with the cautery needle to prevent any unnecessarily bleeding which can blur the fields, because as it's a 9-year-old and the operating space is narrow. Next I use a 50 number blade to make the incisions on the mucoperiosteum. This is in the posterior 1/3 of the septum and the adjacent atretic plate. So now I elevate the mucoperiosteal flap with the help of the microperiosteal dissector. So I'm using a lot of micro instruments used for the ear surgery, like the periosteal elevator and the round knife, the microsuction tips, because the space is very narrow and sometimes the conventional ENT instruments will not have enough place for us to work with. So the micro ear instruments are very useful in this case. As you can see, I'm using the round knife to elevate the flap, make the incision and elevate the flap. So I'm separating it from the overlying vomer bone and the perpendicular plate of the ethmoid. This is on the contralateral side, that is the left side, and the flap is based inferiorly from the floor upwards onto the septum, that is the posterior 1/3 septum. So a good guide is that we should stay below the anterior end of the middle turbinate and not go above that. This way we will not cause injury to other structures. So I'm trying to elevate the mucoperiosteal flap of the bone and expose the vomer and the perpendicular plate of ethmoid. And I reflect the flap backwards and laterally into the inferior meatus. So this is on the contralateral side, the normal side, which has a patent choana. Next, I raise a similar flap on the right side, that is the ipsilateral side, the side with the atretic plate. So I make a L-shaped incision horizontally at the level of the junction of lower 1/3 and upper 2/3 of the septum, and then make a vertical incision right down to the lower 1/3 septum and continue it to the floor of the nasal cavity using the Colorado needle. So this cauterization will help in good hemostasis, and I can raise the flap without much bleeding, and I can visualize well. You can also use a radio frequency needle if you have one, the curved needle. Here I am using the Colorado needle. Then I am using the round knife to make the posterior incision, vertical incision, and then the horizontal one, which is parallel to the incision which I have given anteriorly. So this incision I have given at the junction of the atretic plate and the septum. And now I use the 15 number blade to make the sharp incisions on the flap up to the depth of the bone, just like you would do for a septoplasty. And then I raise the inferior based flap, septomucoperiosteal flap, on the ipsilateral side, as I did on the opposite side. I use a round knife to elevate. This round knife is the micro ear instrument, the Rosen's knife. And I lift it off the septum vomer, the perpendicular plate, and also try to dissect it off the atretic plate gradually with the periosteum elevator. Here I have reached the junction of the atretic plate with the septum, and I lift the flap off the atretic plate. One should not go very high up, otherwise we can enter the sphenoid accidentally. So the guide is the anterior surface of the middle turbinate. So we should stay below that, and that is our safe landmark. So as you can see that I've elevated the flap, and we're trying to tease it off the junction of the septum and the atretic plate posteriorly. And then I see the atretic plate and I perforate it with a suction, direct suction. It's a thin plate, membranous, more of membranous and less of bony. So I could perforate it very easily. Now I'm trying to remove the vomer bone. So in cases of choanal atresia, it has been seen that the posterior 1/3 of the vomer is supposed to be thickened, and the medial pterygoid plate is also medialized. So one must try to drill the medial pterygoid plate and remove the vomer in order to get a wide neochoana. So that is what I'm trying to do. And basically I have done a posterior septectomy. I have removed the vomer and the part of the perpendicular plate of the ethmoid. Now I'm trying to remove the rostrum of the sphenoid and trying to connect both the choana and make it into a common opening. So that the chance of re-stenosis will be very less. I'm trying to remove the bone pieces. You can use a rostrum, you can use a Kerrison's rounger, or you can use a bone punch also. And now I'm using the micro debrider to remove the redundant mucosa over the medial pterygoid and the posterior part, that is the pharyngeal mucosa, over the neochoana. So one can use a backbiting forceps also to remove the septum bone. You can use a Kerrison rounger, whatever is convenient for you. As you can see that I have made a wide choana here. You can see the nasopharynx. And now I'm cutting the intervening mucosa and joining both the choana to make a common opening. This is the tissue over the medial pterygoid plate. I'm debriding that. So the medial pterygoid plate, as you can see, is medialized. So there are many theories for choanal atresia, and one is that there is abnormal migration of the mesodermal crest cells, neuroectodermal crest cells in the choanal part. Also, there will be sometimes a persistent buccopharyngeal membrane which has not perforated, and sometimes there will be abnormal cell rest present in the choanal area. So the incidence is 1 in 5,000 to 7,000 live births. Here I'm using, as you can see, a drill to smoothen out the vomer and make it almost flat. Remove the bony spicules and the rough edges and make it a rounded, nice rounded opening. So I'm using the drill from the contralateral side through the septectomy opening, and while I'm trying to visualize from the ipsilateral side. It's like a two-handed approach for me. As I was saying that choanal atresia, it is commonly seen in 1 in 5,000 live births, and there's a sex predilection more common in females, and it can be seen in twins also. There is no racial predilection though, and sometimes it can be associated with other abnormalities, chromosomal abnormalities in 6% cases, and syndromic, that is sometimes associated with the Charge syndrome or with the Vactor. So here you can see that after having made the bony openings, I'm putting the flaps in place, the ipsilateral flap turning backwards to cover the bare bone over the vomer and the medial pterygoid plate, and the contralateral flap, I have placed it over the floor and onto the floor of the vomer, that is a residual vomer, and onto the floor of the nasal cavity, so that no bare bone is left exposed. It is all covered by the mucosal flaps. This will prevent any circumferential stenosis in future and keep the choana patent. Now I'm supporting the flaps with a gel foam to prevent the falling off of the flaps. Gel foam on the posterior flap and a gel foam on the floor, where I have used the contralateral flap, which is swung over the vomer and onto the floor. So this is a crossover flap technique. I have not used any stent because stents are known to cause restenosis and also cause granulations or scarring. It can also cause columella erosion or excoriation, leading to some scarring or deformity. This is the endoscopy done after 1 month, after the whole mucosa has healed, and you can see a patent neochoana, a common opening from both the sides, with the flaps also, which have also taken up well, and the nasopharynx is visible. So I had called for meticulous cleaning weekly to remove crusts, and use a suction to remove any coagulum and visualize the neochoana. So at the end of 1 month, this is the result which I got. The patient is able to breathe well through the right nasal cavity, and she is extremely happy. This is a flap you can see on the ipsilateral side and the crossover flap on the contralateral. Thank you for watching.